Welcome to our 2023 webinar series for the UCSF Child and Adolescent Psychiatry Portal. Today, for the February session, our topic is autism spectrum disorder. We have a pretty good number of people here right now, so we're going to go into introduction and then start having our panelists to introduce today's topic. My name is Ho-Hui Wang. I'm one of the child and adolescent psychiatrists staffing the CAP consult line. I also help organize CAP CME activities along with my wonderful colleagues, Drs. Joan, John, and Lauren Schumacher. Before we begin, a few housekeeping items. Today's session will be recorded and posted on our CAP website for viewing afterward. If you have any questions during the presentation or after the presentation, please use the Q&A function in the webinar. We will also try to save a few minutes to answer questions live if possible. For the interest of time, I'm going to go ahead and introduce our speakers today. It is a pleasure to have both of our experts, Drs. Milena Kaufman and Enjey. Dr. Milena Kaufman is here with us right now, and Dr. Enjey will be here in just a few minutes. Dr. Milena Kaufman is a child and adolescent psychiatrist for the Division of Mental Health and Child Development at UCSF Benioff Children's Hospital, Oakland, and UCSF Department of Psychiatry and Behavioral Sciences. She's an assistant clinical professor providing clinical care at the UCSF Autism Spectrum Disorder and Neurodevelopmental Disorder Clinic and at UCSF Benioff Children's Hospital, Oakland. Dr. Kaufman is board certified in both general and child psychiatry. She completed her bachelor's degree at University of California, Santa Barbara Medical School at Touro College, adult psychiatry residency training at Zucker Hillside Hospital, and child and adolescent psychiatry fellowship at Stanford University. Clinically, Dr. Kaufman specializes in the assessment of co-occurring psychiatric problems in individuals with autism and other neurodevelopmental disorders, pharmacotherapy, including both medication management and consultation, and behavioral therapy. Dr. Kaufman is also trained in pivotal response therapy, a behavioral intervention for autism. She also collaborates with other clinicians and provides diagnostic assessment of autism and other NDDs. Dr. Enjey is a clinical psychologist and associate clinical professor at the UCSF for autism and MDD in the Department of Psychiatry and Behavioral Sciences. Her specialty area is in the evaluation and treatment of youth with autism and NDDs, including co-occurring psychiatric conditions, particularly anxiety. Her clinical and research interests are in applying and developing evidence-based treatment for youth with autism to treat core symptoms, areas, and co-occurring internalization and externalization disorders. Furthermore, she's interested in understanding the overlap and impact of these two areas on the overall well-being and functioning of youth and their families. She completed her clinical psychology doctorate degree at UC Santa Barbara, internship at Stanford University, and postdoctoral fellowship at UCLA. She has specialty training in behavioral analysis, and she is a board certified behavior analyst, doctorate level. With these information, we'll hand this over to Drs. Kaufman and Lin.
Thank you for having me. I also just wanted to credit Dr. Zara Seftel. She's also one of our child psychiatrists. She put together these slides last year, and Dr. Emma Salzman, who's one of our psychologists in the UCSF Autism Clinic as well. Thank you. Next. And just wanted to notify no disclosures for this presentation. Okay, so our objectives for today will be to review what parts kind of make up an autism diagnosis, what we're looking for, and the frequent comorbidities that we see alongside an autism diagnosis, go through the pharmacological treatments for the comorbidities that exist for children and adolescents with autism, and then talk a little bit about what is involved within an autism assessment and evaluation, and then what are the overall therapeutic considerations and interventions that we have for autism. Next. Okay, so starting with our DSM-5 criteria. So we have two categories when we are thinking about an autism diagnosis, or kind of two buckets as I describe it. The first bucket is around social communication challenges. The second bucket is our RRBs for short, or restricted repetitive behaviors. So in that first bucket around social communication challenges, what we're looking for is challenges with the reciprocity, that kind of back and forth conversation skills. We're looking for challenges with nonverbal communication, and we see challenges with not just initiating and developing, but also maintaining friendships and relationships with others. And of course, in some cases, we also have a speech disorder present as well. In that second bucket, restricted and repetitive behaviors, we are looking for kind of our shorthand stims, or stimming behavior, which is the stereotypic behavior, which can be both verbal and nonverbal. So a classic example may be something like hand flapping or rocking. And then verbally, we would see echolalia, repetitive language. We see insistence on sameness and challenges with flexibility. We see high levels of kind of rigid behaviors in this category. Restricted interests, or highly kind of preferred and narrow interest. And we see sensory sensitivities, such as to loud noises, to bright lights, to certain textures. It can come up with food and eating quite often. And then on the other hand, we see sensory seeking behaviors. So these patients might seek out a certain sensation and want to kind of repeat that over and over again. Next slide. And so outside of those kind of two buckets, which you can see in this image, kind of centrally, we have all these other kind of comorbidities and all these other parts of the diagnosis that can really impact our patients. And kind of around the bigger circle is what we're kind of talk about when we think about treatment for autism. So I think it's a nice visual. So below our two buckets, below the social communication deficits and the RRBs, we see these three other buckets. So the first one is intellectual abilities. And you can kind of see the range. And I think this kind of helps to think about that, right? We're going to have some patients with ASD that do have intellectual delays or are severely delayed, but then it is a whole spectrum, right? So we also will have many individuals that have average intelligence, and then some individuals that actually are above average in terms of their IQ and cognitive capabilities. And then in the middle, we see language skills. So yes, we may have individuals that are nonverbal and cannot communicate using language, but then we will also see many patients that are completely fluent, and that would not rule out an autism diagnosis. And then that last bucket below is around adaptive functioning. So we can have patients that are really struggling with their adaptive functioning, and then all the way along that spectrum to where individuals are independent. And it's not always completely tied to their intellectual abilities, because we may see individuals, do well in some areas, but let's say socially their adaptive functioning or their ADLs may be really challenging because of the autism diagnosis, even though their cognitive ability is average. And then in the bigger circle, we have our comorbidities, right? So we may be seeing neurological disorders like epilepsy. We may be seeing ADHD with hyperactivity and impulsivity. Sleep disturbances are very common in this patient population. We may have irritability and aggression. We may have more medical concerns around GI disturbances and GI symptoms that contribute to things like the irritability. We may have anxiety disorders. We may have specific genetic disorders, which is why we commonly will recommend genetic testing. We may see depression. They may have motor challenges, and we may see comorbid OCD symptoms and diagnosis. Okay, next. So when it comes to comorbidities, certainly more common to see them in patients with ASD than in the general population. About 70% will have at least one comorbidity, and then around 40% will diagnose with two comorbidities. Of course, the prevalence rates are variable. And I think one of the most important things is that they certainly can be challenging to diagnose with autism, because many of them on the surface could present quite similarly. It may sometimes kind of take quite a bit of investigation to kind of figure out and really kind of identify, is this part of the autism diagnosis as a whole, or is this a separate comorbidity? And when we do have comorbidities, they will often kind of escalate the severity of the autism symptoms themselves. And I'll explain that a little bit more. Next, please. So when it comes to psychotropic medications in this patient population, so over 50% of our patients with autism do take some type of psychotropic medication. Unfortunately, overall, we have limited evidence in this patient population. There's, to kind of begin with, not many studies as there are with neurotypical patients. And one of the biggest challenges we have when it comes to using psychotropic medications is we do not have medication for those core symptoms of autism. So if you kind of remember that first image with our two buckets in the middle, the social communication challenges and the restricted repetitive interests and behaviors, we don't have medications that directly treat those core symptoms. So when we are using psychotropic medications, we are targeting that bigger cluster. We're targeting those comorbidities and those symptoms that we may be seeing on the surface that, of course, may then later exacerbate some of the autism symptoms themselves. And unfortunately, our patients often are much more sensitive to medications. And so the motto is always start low and go slow. Okay, next slide, please. Okay, and so the big question often is, when do we even kind of start to consider medications, especially, right, if we don't have a medication that's going to treat that core symptom? So we always want to first assess, what services is the patient currently getting? Are they getting ABA or some form of a behavioral intervention? Are they getting speech therapy? Are they getting occupational therapy? What services are they getting within the home or the school or their environment or community? Are they getting any types of additional therapies aside of those kind of standard, the ABA, speech and OT? Are they getting any parent management training? Are they getting cognitive behavioral therapy or social skills training? Of course, wanting to rule out medical causes, because especially if we have patients that have lower verbal skills, are we seeing aggression because they're in pain or there's some sort of discomfort, and that's the way that they're communicating that, and always wanting to rule that out first. And so, of course, right, our main goal is identifying, are there comorbidities and what are the target symptoms if we are going to use a medication. And as kind of boldly, stated here, considering medication right after we've carried out a functional behavior assessment, or FBA for short, and we've maximized, all of our behavioral interventions first. Okay, next slide. Okay, so these symptoms probably parents bring up quite often with individuals with autism: hyperactivity, impulsivity, and inattention. And so, of course, these are symptoms we can be seeing within ADHD. One of the challenges is that, and as in this kind of third bullet point, we often see more hyperactivity than in the inattention, because the inattention piece often may be part of the autism itself. And so when it comes to kind of thinking about treatments, that's important to know, because we may be seeing the hyperactivity side improve, but parents may still be reporting challenges with inattention. But that may be more due to, let's say, a child or adult with autism responding to internal stimuli, or kind of being hyper focused on a preferred interest and not responding, as opposed to that it stemming from the inattention piece that we would see with, let's say, a neurotypical child with ADHD. So some of the medications that we use, stimulants, those are still our first line for ADHD symptoms, alpha agonists like guanfacine and clonidine, and then additional non-stimulants like Strattera or moxetine. Next slide, please. Okay, so a little more detail in terms of stimulants. So we have our two categories, the methylphenidate and the amphetamine. We do have evidence, again, not a whole lot, but the evidence that we do have that supports using methylphenidate. Again, we still do have lower response rates and more variability in the outcomes in individuals with autism than those that are neurotypical. And we do unfortunately have more side effects, similar side effects like the decreased appetite and insomnia. But then we may see a little bit more of the irritability and the emotional outbursts as a side effect with our patients, especially if they already had some baseline irritability or self-injury or aggression. And again, they may be more effective for the hyperactivity than the inattention piece. We often start with the methylphenidate family because we may be seeing more side effects on the amphetamine side. Okay, next slide, please. Okay, so when it comes to then our non-stimulants, so the guanfacine and clonidine, we do have some evidence for using those in our patients, can be helpful for hyperactivity, impulsivity, some mild improvement with the inattention, and we may have some less side effects than we do with the methylphenidate stimulant with our patients. We can see some reduction in some oppositional behaviors, some mild reduction in some repetitive behaviors, but not a whole lot of improvement for anxiety or sleep that it may have with a neurotypical patient. Again, there still might be some improvement, but not as much as we would have with a neurotypical patient. Similarly, with clonidine, we have some evidence for improving hyperactivity and inattention, self-stimulation, and some improvements in aggression and irritability. And clonidine may be actually more helpful than the guanfacine when it comes to addressing some sleep concerns with our patients. With Strattera or moxetine, we only have a few studies showing some effectiveness, but maybe a good option if, let's say, a patient wasn't tolerating the non-stimulants due to, let's say, blood pressure. Okay, next slide, please. Okay, anxiety, depression, and OCD. So again, kind of going through that bigger bubble of the comorbidities. So these kinds of internalizing disorders may be harder to identify in individuals with autism. They may drive disruptive behavior. So again, on the surface, what we may be seeing is just more aggression, more meltdowns, but the cause may be quite different. And kind of what we're investigating and trying to figure out because the treatment may look a little bit different. We see these sometimes in higher rates with higher functioning patients. When it comes to anxiety disorders, when we kind of visualize that in someone with autism, what we sometimes can see is an increase in ASD core symptoms. So for example, if a patient with autism has more anxiety, what we may see on the surface is more repetitive behaviors. They may be engaging in more stimming behaviors as a way to kind of express or cope with the anxiety that they're experiencing. And that can be exacerbated by sensory sensitivities, by transitions, by changes in their routine, things unexpected coming up that can kind of create more of those RRBs that we see or more meltdowns on the surface. So our first line treatment for these disorders would still be an SSRI, just like in our neurotypical patients. Again, we would start low and go slow with the titration, and we often also use hydroxyzine or Atarax as a PRN, especially while we're titrating the SSRI to an effective dose. And then less often, we may be using gabapentin, Buspar, or propranolol to treat these kinds of symptoms. Okay, next slide, please. Okay, SSRI. So we're treating the serotonin, dysfunction that there's been reports of within individuals with autism. We're targeting, again, the anxiety, the depressive symptoms, or the OCD symptoms. We do prescribe them often with individuals with autism because we often do see symptoms of anxiety, but we still have very little evidence that makes significant improvement. Although clinically we may be seeing that, we don't have large studies to kind of back that up. Most studies are evaluating the SSRI's efficacy for RRBs, and we often don't see improvements in the RRBs, which is kind of going back to that, sentence at the beginning that we don't have medications that treat the core symptoms of autism. So the side effects that we're monitoring for, one of the ones we're most concerned with our patients is the activation side effect of SSRI, which may look like hyperactivity, irritability, impulsiveness, and sleep disturbance. And this may actually limit us from being able to continue titrating or using the SSRI. It is dose dependent, and it is kind of more possible when there's a more rapid titration, but it can happen even at a low dose. And the SSRI that this happens most frequently with is Prozac, but it can occur on any SSRI. And the response, fortunately, is highly variable and may be, very effective for some patients with autism and not for others. Okay, next slide, please. Okay, so this is kind of a helpful image for kind of what I was describing in terms of on the surface, right? So above the water, right, is what parents are reporting they're seeing or what the teacher is reporting seeing, right? And underneath are all of these possible reasons that are contributing to that externalizing behavior that is on the surface. So again, parents often may come and share concerns around irritability, aggression, or self-injurious behaviors. These are more common in individuals with autism that also have intellectual and language impairments. So you can imagine they may be getting very frustrated, not being able to communicate their needs and not being understood. So what we kind of think about when parents come in and are reporting irritability and aggressive behaviors about self and others, we have kind of this kind of clinical approach that behavior is really a function. So the behavior that's happening on the surface, the patient is doing for a reason, and we're trying to figure out what that reason is. So that's why we always recommend performing a functional behavior analysis, and that can often be done with ABA or and in schools. Sometimes they'll have the psychologist or come into the classroom and really observe. So whatever setting the behavior is happening in, what's happening before the behavior and what's happening after, so that we can really figure out what is the purpose this child or this patient or adult is having this behavior. We want to, of course, evaluate and treat any medical or psychiatric comorbidities. And then when we are unsuccessful with improving the aggression, after we've kind of figured out behaviorally and what behavioral modifications we can make, after we've treated any possible comorbidities that are contributing to the aggression, our last resort is using an antipsychotic. And I say last resort because, of course, there are more side effects that we have concerns about that we will go to if we need to, because, of course, we want to keep patients and those around them safe, but kind of weighing in risk and benefit and making sure we're addressing things behaviorally first. Okay, next slide, please. So the two antipsychotics that have been FDA approved are Risperdal or risperidone and Abilify or aripiprazole. That we do have studies. These are kind of the one group of medications we have the most studies to show effectiveness within our patient population. And it can treat irritability, aggression, self-injury. We do see some improvement in stereotypic or the stimming behaviors. And we can see some improvement in some hyperactive and impulsive behaviors as well. Okay, next slide, please. So this is just a nice graphic from kind of comparing and really showing the difference between a placebo and the risperidone. You can see quite a significant impact in terms of reducing the aggression. And it is certainly, again, a medication group that we will use because we know the impact can be, really significant. We just want to make sure that we've tried other treatments as well before going to it. Okay. Next slide, please. So if we are using an antipsychotic, we do have some things we're monitoring for. So the side effects we're worrying about are increased appetite, weight gain, increased risk for metabolic syndrome, which we see a little bit more often with the Risperdal than the Abilify, sedation, and possible but low incidence overall because we're using quite low doses, at least starting at very low doses of EPS, extrapyramidal syndrome, or TD, tardive dyskinesia, which is more of a risk for long-term antipsychotic use. With Risperdal, we're also monitoring for gynecomastia and drooling, and with Abilify, we are monitoring for akathisia, which is kind of a restlessness or a pacing that can be quite uncomfortable for patients. We want to monitor weight at each visit. We have metabolic labs that we are monitoring with lipids and hemoglobin at 3 months and then every 6 months. And we are kind of constantly reevaluating at every visit. Do we need to continue the antipsychotic? Are we at a place where we could lower it? Has the patient now received ABA services and has improved coping skills? Do they still need the antipsychotic at that same dose? So that we're not just kind of refilling over and over again when we potentially may have made really great, improvements in the patient's behavioral treatments, so that we can adjust and lower these medications so that we can limit long-term side effects. Okay, next slide, please. Okay, sleep-wake disturbance. These come up very often with our patients: difficulty falling asleep, difficulty staying asleep, waking up too early in the morning. We see it more common with individuals that are lower functioning. There's kind of lots of kind of back and forth. Behavioral problems can lead to problems with sleep, but then it's bidirectional. So if they're not sleeping well, that's contributing to behavioral problems later the next day. And so it becomes this cycle. We always want to first start with behavioral interventions. And we don't have a whole lot of evidence for sleep medications, even though they're very commonly prescribed in these individuals. What we want to, again, do is treat any possible comorbidities if those may be impacting sleep. So is there anxiety, and that's what's making it hard to fall asleep? Melatonin is effective at decreasing sleep latency, and it is kind of our first line after behavioral interventions when it comes to trying to shift and improve the sleep pattern. And of course, kind of always wanting to do that for a short period of time while we're trying to get the sleep back on track. And then this is just a lovely image for the bedtime routine. We always recommend using these kinds of visual schedules so that we can kind of help these patients kind of build a routine and good sleep hygiene in a way that they can understand. Okay, next slide, please. So this is just an image kind of showing, again, we talked about it, how much evidence and for which medication. So the Risperdal and Abilify, again, we have the most evidence for in our patients. And then we have some evidence, stimulants, and then non-stimulants like the alpha agonists, and then even lower in that some evidence bucket for SSRIs, the non-stimulant, Strattera, and then for anxiety, buspirone, and then melatonin. And on the other side here, we have limited or almost no evidence for a significant impact for individuals with autism. That being said, it doesn't mean that we don't use it, but there's a list of medications, including Remeron for sleep, propranolol, benzodiazepines, mood stabilizers like lithium, sleep medications like trazodone. So again, I certainly have patients with autism that are on trazodone that didn't do well with melatonin, but I cannot back that up, showing families, here's the research study where, I know it's going to make an impact, but we may still be using kind of thoughtful trial and error to see if these would be a good fit for a patient. Next slide, please. Okay, I'm going to hand it off to Dr. Lin to go into just more depth and detail in terms of kind of screening and the evaluation and diagnostic process.
Great, thank you for having me. All right, and so we're going to transition a little bit in terms of diagnostic considerations and treatment considerations for patients that you guys work with who you are concerned have ASD or may have ASD. And as you're very familiar, screeners are a big part of your job, and you guys have so many different demands. Families do refer to their pediatricians, and they're the first people that they reach out to. So one of the things that you guys may be very familiar with is the use of level 1 screeners. There are 2 levels of screeners. And the first one really is just like a broadband screener, as you guys are very familiar with. They have high sensitivity, and they're meant to be used in the general population to catch children who are at risk. So it's like a wide blanket in order to catch kids who may be at risk, who are not yet identified. And one of the most common questionnaires is the MCHAT that I'm sure so many of you guys provide to the families you work with. There are also the level 2 screeners, and I'm not quite sure how many of you guys use those, but this is a little bit different. This is for kids who you know are at risk for ASD. So maybe they failed the MCHAT, so there were scores there that were elevated, and so you have a parent concern for it, or there's some kind of already observed or known developmental concern, or they have a sibling with autism. And those would be things that are more kind of observation based from the physician. There's the one that's a checklist type with your observations. That's the autism detection in early childhood. And then there are more interactive screening tools that you would do in the office with kids with a certain set of toys. And one of those is called the screening tool for autism in toddlers and young children, called the STAT, which does require a little bit more training, but they provide that online. But these are the type of screeners that are generally used and can help aid with knowing who am I going to monitor and who am I going to start to refer out to get evaluations and treatment. Next slide, please. So there are some concerns with screeners that we should all think about, especially with the questionnaire-based screeners, the level 1 screeners. The research is showing that with non-English speaking families, with racial minorities and lower income families, fewer families are getting screened, which means that we're missing this portion of our population. And that some of these screeners actually do come with some follow-up interviews, especially the MCHAT, for items that the family endorsed, to get some more follow-up information, because the screeners themselves, families might not know what the questions might be specifically asking for. And so they might be answering items saying that a behavior is not present when it might be. And so the actual physician speaking with the family and gathering information, that's really important. And that, follow-up interviews are just less likely with screenings, which makes sense. There's just so many different things physicians, pediatricians are having to take into account at well child checkups. So there are some possible solutions to this, like just having increased staff support, or doing some of these screenings in person rather than having parents do them online or only in the office, but actually providing them, administering in person. And then including thinking about childcare providers who may help with doing some of these screenings or even getting input from them. There's also some gender differences as well. The MCHAT seems to be less accurate in picking up girls and boys, and we'll talk a little bit more about gender differences. And there's concerns that, these screeners, these level 1 screeners, may not capture some of the nuances and some of the subtle early signs of autism, which we'll talk about a little more. All right, next slide. All right, and so here's where, the pediatrician plays such a big role. So, the screeners are helpful, and the pediatrician's clinical judgment is really important. And we just talked about how you guys are pediatricians are juggling so many different things. There's other conditions you're having to look out for. And there's so many resources, right, that one can have at community clinics. And so it can be quite challenging to do all of these things. but there's some information from research that can be helpful in thinking about how do you kind of weigh all of these things and really find a way to get parent information. As we talked about, pediatricians are usually the first point of contact for any type of concern that parents have for their children. And so if pediatricians can elicit some parent concerns during those appointments, that really helps to facilitate that conversation. But sometimes parents, as we said, just don't know, or maybe they are not aware of what some developmental milestones are. And that might be when we ask broader questions rather than, are you concerned? But kind of tapping into, do any of your family members have concerns for your child, or your early childcare providers, or school or professional providers? Like from early intervention program providers. And it may be helpful for the pediatricians to reach out to some of these other caregivers and professionals that children are interacting with in order to get a better sense, especially if pediatricians have some concern and maybe parent concern isn't fully present. Next slide. All right, so there's a lot of research examining parent concern, and there's really strong evidence that parent concern strongly predicts, whether or not you're going to get screen positive on these screeners, and also diagnosis of autism, whether or not that's more likely, as well as severity of autism symptoms. So the earlier parents have concern about autism generally correlates with children having higher severity levels, and lack of parents' concern results in delays to diagnosis. As we said, lack of concern may be that child actually isn't presenting with concerns at that time, but it also might mean that the parent is missing on some of these things or not yet ready to acknowledge some of these things. Next slide. With parent concern, the research is showing that usually parents are concerned with their children within the first 2 years of their life. So a third of parents actually had concerns even before the child's first birthday. And so this is really important to keep in mind, because parents of children who are getting diagnosed with autism later, they've had concerns very early on in their childhood's development. When parents have concerns at 12 months old, when their child's 12 months old, it is very strongly predictive of an autism diagnosis. And, the reason why the first 2 years of life is so important is because symptoms emerge gradually over time. Something to think about is sometimes the first concerns, or the most maybe common or earlier concerns that parents will share, is that their child has a delay in their language, or there's some aspect of their social communication or engagement that's kind of off or missing. And these are where you would use your broadband screeners. Then over time, especially by 12 months and on, there are additional concerns. They are more about behavioral or motor differences. These would be things like the repetitive behaviors that's come online more after the child is 1. And these might be times where you use more of those ASD specific screeners, the level 2 screeners. All right, next slide. And, among those people, the families who ended up having concern for their child and flagging it to their pediatrician, among those families, even though their children did later on get the diagnosis, only 5% of the families thought what they saw was autism. Many of them actually didn't really know what these differences in their child's development really were pointing to, but they were picking up on important developmental differences. And so that's really important to keep in mind. They might not know what the diagnosis or what the constellation of these things are, but they are very intuitive, and they're really picking up, hey, there's something different about my child. Also, for those who passed the first screen, they might, let's see, they've passed the first screen, but then some of them later fail the subsequent ones. And so this is why it's very important to repeat screenings over time across the well-child visits, and even a little bit more frequently, especially if you, the pediatrician, is having some concerns, because the first pass might be a time where maybe parents are not noticing or picking up on things, or like we said, the development of symptoms just hasn't yet kind of evolved in order for families to be able to notice any of these concerns. All right, next slide. So there's a real disconnect between the knowledge we have, the science and knowledge behind understanding diagnoses, and what really happens in the community and in real life. Even though we know that, children can be diagnosed very early, even by the age of 2, often diagnoses are not made until 4 years old or later. So that means we lost 2 years of time with these with these children whose parents had concern pretty early on. Sometimes what happens too is that, I think we all want to give children time to grow and time to not alarm families. But what happens sometimes is that for pediatricians who want to wait when children are young and their parents have concerns when their children are young, the wait and see approach, it really does delay the timeliness of getting evaluations and the timeliness to access interventions. And so, it's really important to kind of act on parent concerns and to refer families for evaluations, even though children are young, because science tells us that kids actually demonstrate and show symptoms starting from age 1 and more robustly by age 2. Something to keep in mind too is that autism symptoms present much earlier than intellectual disability, and so families of children who end up having a diagnosis of intellectual disability, they end up having concerns much later than concerns with autism. So if you're having families who are saying, my 1-year-old or 1.5-year-old, I'm concerned, that's kind of a red flag for, I actually might be seeing autism here, the early beginnings of autism, and let me get that family connected to getting an evaluation. Of the 40, one of the studies from UC San Diego showed that among all the positive screeners within some community developed pediatrician clinics in San Diego, only 40% of those kids who demonstrated, met the cutoff levels on the MCHAT were actually referred for an evaluation. So there's 60% of kids, the rest of the kids who did not pass the MCHAT, who actually were not referred for an evaluation. That's very concerning. Next slide. All right, so research is showing that when pediatricians are proactive, they are quickly responding to parent concerns rather than saying, let's wait and see. The children and the families are getting ASD diagnosis much faster. Those pediatricians who were more passive or reassuring, it led to delays in autism diagnosis. And so if pediatricians strongly feel that they want to wait before they refer for an evaluation, then it should be that there's a specific deadline where they decide, if I don't see gains by this time, then I'm really referring them, the family. And it should be more active and more frequent monitoring. Maybe that's when you're starting to use your level 2 screeners, right? So using additional tools to really help you make a decision, especially if parents just, express concern, but maybe you're not seeing it in the clinic. It looks like there's about a delay of 3 years for a lot of families when they first say that they're concerned to their pediatrician, and then when the child actually receives a diagnosis. And so that's really important to kind of think about. There's a 3-year gap when parents were initially concerned, and then the children finally got an evaluation. We really want to increase or speed up the time kids can get an evaluation, because we know with early treatment that even by 21 months of age, kids are really benefiting from intervention. And there's information showing that the younger the toddler is, the greater gains they make compared to older toddlers, especially with social communication gains. So that, their brains are growing so rapidly. So the earlier they're accessing treatment, the better and bigger gains that they're making. So the one thing we would say here is, when in doubt about a child's development, whether it's from you or the parent, just refer out for an evaluation, because we will save families and children a lot of time and be able to get them access to treatment as soon as possible. Of course, there's lots of barriers to some of this with long wait lists everywhere. Next slide. So how can we help you guys? One of the things to think about is maybe some tidbits or little golden nuggets you can take away to help you make some clinical judgments with certain kind of tricky cases. We'll present a couple of different things that you can maybe take away and keep in your back pocket. So one of these things are about autism and language. And we know, and we just talked about how language delay is commonly the first thing that parents report for their kids who later on have a diagnosis of autism. It's the language delays. A large portion of kids end up having some language across time. They might end up at single words, simple phrases, or even complex language. But about 30% of kids with ASD end up having this label of being minimally verbal. They have a persistent language development despite intervention. So that's between 3 to 5 years of age that you start to judge that. Oopsie. There you go. And there's so many different parts of communication. There's expressive language, receptive language. And with that, those are the fundamentals, right? What is their structure of how they talk? What is their grammar? But something to keep in mind, especially for those kids who do have some language, is the pragmatics and the quality of that language, right? And so, I think we often know what a prototypical, child with autism might look like, especially those who are more impaired, who have more significant delays. I think it's tricky when we get kids who are talking, right? But you want to look for the pragmatics. How are they using their communication? What's the quality of how they're communicating? Listen for, are they making comments, right? Are they having conversation, especially kids who are already at phrase language? There should be a back and forth. Are they asking questions to learn about the person? And so you're looking for these types of things to see, okay, I hear that they talk, but what is the quality of their talking? How are they using their talking? What you want to see is higher level forms of social communication. They're talking to comment, they're talking to learn about you. There's a back and forth to their conversations where it's, you really feel like they're engaging with you and it's not one-sided. Next slide, please. The next one that we want you to kind of take away is about autism and intellectual disability. There's a lot more variability with understanding whether or not kids with autism also have co-occurring intellectual disability. And it's lower in terms of the prevalence than initially we thought. In the past, it was thought there was a high prevalence, or a majority of kids who had autism also had intellectual disability. But now through clinical and population-based samples, we're finding that there's also a really high portion who have average to higher IQ. And so that's a little different from maybe what we initially had thought what autism looks like. And that's why we have to be really thoughtful and careful, especially looking at some of these other things like, yeah, they're talking, yeah, they're going to school, but what is the quality of how they're interacting with other people? And as I talked about before, kids who end up with a diagnosis of autism, their families had concerns much earlier than the children who later got a diagnosis of intellectual disability. Next slide, please. Another thing to keep in mind is about autism and social interests. So there is a big range of social interests. It's not the idea that we thought before, where we thought, people who are on the spectrum, they are just really disinterested and aloof. Sure, you do have that. And then there are those people who are actually quite interested in other people. They want to engage. They really initiate a lot. But what you see is they are very interested, but they're very inconsistent in their skills. What we see a lot of is they initiate a ton. However, they're not reciprocal, they're one-sided. And so they don't seem to really kind of take in as much as what you're saying, but they're very excited to share with you all of their thoughts and interests and observations. And those who have higher verbal abilities, what you see is actually two sides of a coin. Some of them do have milder social impairments and repetitive behaviors, but others have more severe social impairments and repetitive behaviors. And what we might think about with those kids is those who have higher verbal abilities, you might see kids with very strong restricted interests. And so it's really impairing their ability to engage and be with others, even though they have very strong verbal abilities. All right, next slide. The other thing to think about, and there's more research on this now, is ASD in females. What the research is consistently finding is that they do meet the same type of criteria as boys who have autism spectrum disorder, but what you're finding are differences in how the symptoms manifest. In particular, you're seeing much milder, restricted, repetitive behaviors. And the special interests they have are more female-related special interests, like American Girl dolls or unicorns. But what you start to see is that there is a difference in the intensity and exclusivity of their interests, and that there's a functional impairment, that they have the same interests as other girls, but they're more into it, excluding other ways of connecting with other people or with play, and it really impacts their ability to interact with other people. What we're also finding is that they have more social interests and milder social communication impairments. Research is showing that their level of social interest and social communication impairments, they actually end up being at the same level as a typically developing boy than a typically developing girl. So you're seeing reduced frequency and quality of their social communication, social interests, which can make it very tricky to kind of figure out, am I seeing autism in this little girl? She is social interested, she is making comments, right? But you're seeing reduced rates of these in quality that's similar to a typically developing boy. What you see with girls who end up getting a diagnosis is they're more often socially excluded than socially rejected, and that they really seek out friendships, but they find difficulty maintaining them. Girls with a diagnosis often receive a later diagnosis. This is different because it used to be the idea that girls who have a diagnosis of autism were more severely impacted than their male counterparts. That's true, but those were kids who are very severely impacted. What we're learning now is that girls are actually those with milder presentations and who have intact language and intact cognitive abilities. They're being diagnosed much later because the social demands are getting much higher. Adolescents and later on in life, they're experiencing more social challenges and more adaptive functioning challenges. Next slide. Sensory differences in repetitive and restricted behavior is very important to think about because we see this in all aspects of development, typical development, other neurodevelopmental conditions and psychiatric conditions. What you want to see with ASD is that these sensory differences, these repetitive behaviors, are causing functional limitation. There's a difference in how intense these interests are or these behaviors are. The trajectory is different. It's not waning. They're pretty stable and not decreasing over time. And some of the restricted repetitive behaviors that are very familiar to guys are motor sensory behaviors, right? Hand flapping, spinning. But we want to think about the higher order behaviors. These are things where the kids add some kind of idea of how the order should be in their daily activities or their lives. Things like insistence on sameness behaviors that emerge much later and cause a lot of functional impairment. Next slide. All right, so we're going to transition now into information about treatment so you guys are well informed and can also guide the families that you work with. So the most robust evidence shows that kids with autism do the best with skill-based treatments. This means active practice of skills rather than general play therapy or psychodynamic or psychoanalytic type of therapy. Those are less impactful because people who have ASD, they really need explicit explicit teaching and active practice and direction rather than leaving them to infer how to connect the dots. Parent involvement is also key, especially parent coaching. This is true for most children, but especially true for kids with ASD who really have impaired executive functioning, and they also have really impaired generalization skills. And so they really need the support of parents to be able to use the tools that they're learning with the therapist. We also know that treatment has to be personalized. The more personalized a treatment is that is targeted to their goals, incorporates their interests to engage them in treatment, that's often better than something that's very generic and given from each child to the other child. And we often think, oh, ABA is the therapy and that's all they get for the rest of their life. But that's not true. The types of treatments they need really evolve as people with autism spectrum disorder change and grow over time. And they develop co-occurring psychiatric conditions or the nature of their core autism symptoms change over time. There are many types of goals with treatment, like we talked about, treating co-occurring psychiatric conditions, as well as treating things like adaptive behaviors, daily living, functioning, but there are things like play skills and conversation skills. So it's not just about addressing problem behaviors. And we know that early intervention is associated with improvements in language, cognitive functioning, and changes in ASD symptomology. Next slide. Two last things I want to share with you. We all are very familiar that children who have ASD benefit from applied behavioral analysis, but ABA, which is really means a science of teaching, is for anybody and everybody actually, but it is very helpful for people who have neurodevelopmental conditions, including intellectual disability. So ABA is not just for autism, but it's for people, neurotypical people like us, but also especially helpful for people who have any type of neurodevelopmental condition, including intellectual disability. There are two branches of ABA, and one is discrete trial training, which is very, very structured, and the other is what we call naturalistic developmental behavioral interventions. These are more play-based. They take into account a child's development, and there are these two families of ABA that families can be aware of and request. NDBI-based interventions, there's several under that umbrella. One of those is Project Impact, which is what we provide here at UCSF, and it really takes into account and teaches through play rather than very structured learning opportunities. Next slide. And the last thing is the other types of treatments that people with ASD benefit from. Cognitive behavioral therapy, there is more and more research showing that this is probably a very promising treatment for kids who are on the spectrum for treating things like a co-occurring anxiety condition. But there's also research showing that, hey, maybe CBT can actually be helpful for treating core autism symptoms too. And this is a big benefit because it can help boost some of the areas that maybe behavioral interventions can't address, because it takes into account the way somebody thinks and feels as well, and not just trying to teach new adaptive behaviors. But there are also social skills interventions. And the reason why we put this one about young adults is there are treatments for young adults too. So treatment is not just for children or young children, but it's treatment across the lifespan, including those for young adults as well. Last slide, I think I'm at the end. All right, here we just have some tools for you guys. These are tools for families that you can give to them so they can be better aware of what types of developmental milestones their children should be meeting. And then the last slide, next slide, is for pediatricians. For you guys, this is a source where you can actually look at the different type of screening tools out there so you can pick which ones would work for you in your clinic. And that's it.
Thank you both so much, Drs. Lane and Kaufman, for the fantastic presentation. We have one more minute for Q&A, and also before that, just wanted to make sure that we show you all the participants the link to collect your CME credit for today. Also, some information for our next webinar in March. Please make sure to use this QR code on the left, or scan the code, or you can go to the link that's shown in red on top of this page to collect your CME credits. For the next webinar, it will be on in March for bipolar disorders and psychosis, led by Drs. Manali and Steinbuchel on March 9th, 2023, also on a Thursday from 12 to 1. We have 1 more minute for the live Q&A, and we have several questions in line. So there are a few questions about how does COVID make a difference in recognition of the diagnosis in terms of isolation and lack of social interaction? So that's one question. And the other question is about resources. A lot of questions came in for resources for ABA, for autism evaluation.
Yeah, I think there's wait list everywhere, unfortunately, in terms of evaluations. Our center here at UCSF, the Center for ASD and NDDs, our wait lists are open, but families have to have insurance in order to be able to access us and be able to receive an evaluation. And we are seeing all children. Right now, we're taking a pause on adults just because we're trying to prioritize children. In terms of COVID, and it does create some barriers, especially thinking about access to peers and access to other people, especially during the initial parts of COVID. And even now, where some families, because of various reasons, still have to be very, very careful for health reasons. But it doesn't make it impossible. Children still do have warm relationships with their caregivers. There are ways to kind of assess how are kids doing with other peers at parks and open spaces. And then in terms of evaluations, I think at our center, we do have to wear masks, but sometimes what we do is we try to see the kids in their home over telehealth to see how they interact. And sometimes in the lobby or different ways where we could see kids without their masks on. But it is unfortunate because we, the providers, have our masks on the entire time.
Thank you, Dr. Lane. And the final, maybe 2 questions. There's a question about language loss seen in autism at all. The other question is about any good primary care level screening other than AMCHAD that you can use for a broader age group of patients.
That link that I provided actually provides like a wide range of ones. And there's an article. So whoever asked that question, if you could just maybe send me an email or somehow the email is directed to me. There is a research paper out there that looked at which screeners were better. MCHAT was one of them, but there are some other ones too that I could send the paper to. And there was one more question, but I kind of forgot that now.
The other one is language loss one of the symptoms for autism?
Maybe Milena, you can say something about this too. It's not that it's common, but it is seen in some kids who have autism. And also those are the kids that we're concerned might have a genetic condition or something else that's also going on with their development. We definitely do see that in some of the kids, but it doesn't make up the majority of them.
Yes, I completely agree. And I think the only thing I would add is sometimes we can see selective mutism as well, like if there's a comorbid anxiety, and that may be explaining why there's kind of on the surface seemingly like there's language loss.
Great. Thank you all so much for your participation and attention. And I think there are 2 PCPs sharing questions about their CME credit. We can take that offline. Thank you both again. And we look forward to seeing you again on March 9th for our next webinar.